muy buenos días. Estoy listo. Todos los casos nuevos. All right, let's hit start, please. So again, this is a good, very good case. This will happen to everyone. So I'm operating here. It's me. There's my name. Looks like a routine case. Maybe posterior subcapsular cataract. And okay, getting a good Rex is done. So I'm expecting a normal case, nothing unusual. No prior, if you pull out of the eye, what happens?
You lose pressure in the anterior chamber, so posterior pressure is higher than the anterior chamber pressure, so vitreous will go up.
And the hole get bigger.
Yeah, for sure. Now, why did this happen? What happened? Why? Mala suerte nomás?
Because you must use your jack laser,
Yeah.
like yesterday.
So you don't clean the capsule. You had that little piece, you wouldn't pull it.
Now we clean the capsule. We clean the capsule.
Wait, who will pull that piece? Come on. I will pull it, see? And now look, then we suffer. So I don't know.
Too much vacuum.
Maybe, I don't know. But okay, let's see what we do next now. So okay, I'm gonna follow your advice. Position 1, with the left hand, inject dispersive viscoelastic, and then slowly go position 0 on the foot pedal, and then slowly pull out. Okay, it's a big opening, wow. Now what to do? Okay, now.
I will go for a vitrectomy, anterior vitrectomy, and put a 3 pieces lens.
Do you need
maybe in sulcus.
How much vitreous has prolapsed? Do you need a vitrectomy? Who says yes, you need a vitrectomy? You need? Yes, the posterior capsule is open. Yes, vitreous already prolapsed. No, use Wexel and scissors to cut the vitreous. Or D, no, anterior face intact.
D.
You think D is intact? How do you know?
Because the pupil is in the same place. The anterior chamber is in the same place. Maybe you can put your IOL, optic capture, and see.
What do you think? Can I put triamcinolone now, or is it too late? Because I already have dispersive viscoelastic now. Maybe it won't stick.
Yes, you can use triamcinolone, yeah.
But will it work? Because I already put so much dispersive viscoelastic,
yeah.
Maybe the triamcinolone won't go to the vitreous. So if you want to do vitrectomy, how do you know you have to do it? How can you even tell? That's the question. I don't know. What's the answer?
Transinolone?
But I already put the viscoelastic.
Okay.
I would do it the same as Ticiano. I will just put the lens, put some myocol, and see how the pupil moves.
And then if you need to, after, you can do vitrectomy.
Yeah.
I think I like that idea. But I agree. I think anterior is intact. It looks okay. We're very careful. So I think it's okay. Right? I don't see, you can't always see the vitreous. So I'll put more viscoelastic, because I'm just thinking, I don't know what to do. This is a real case from Beverly Hills. This patient paid a lot of money for an open capsule. So now I gotta think, what are we gonna do? Now there's probably still some cortex. What do I do with this cortex here? Oh, what do you do for the lens? Okay, you said put the lens now, let's do it. Single piece acrylic the sulcus? Of course not, never do A. Could you put a single piece in the bag with haptics 90 degrees away from the split?
It's a very big hole.
Big hole?
For use the bag.
So you like C or D? 3-piece sulcus with optic capture? D. That tends to be the safest bet here. So now we're happy that, like you, Neto, at the beginning, we measured the Rex as 5 millimeters. So now hopefully we can get the optic capture. If you put the lens in and it doesn't want to sit, what does that mean? It's probably vitreous. Probably vitreous then. Then we can see. But I like the idea, if you put the lens now, you can always do if you need to do vitrectomy, you can do it. Put the lens in the sulcus, see if it sits, maybe you'll get lucky, and then maybe you don't have to do an antivitrectomy. So in this case, yeah, I agree with you. So 3-piece in the sulcus, I'm gonna try for an optic capture as well. So the only change I'm making in the IOL power is the difference in the A constants. So instead of in the bag 119.2, it's optic in the bag or behind the Rexes at 118.7. So I'll just drop the IOL power by half diopter, and I think the patient should be okay. Luckily, this patient wants monofocal lens. So I don't have to worry, it's not toric, it's not trifocal, it's not EDOF, so we can do it like this. So here we go. I think we'll enlarge the incision first. I know that I don't want to suffer. And you can tell it's Beverly Hills because I'm using diamonds. So I'll enlarge the incision because I want to be able to put the 3-piece in without any grief. Here it comes, and I always remember 7L rule. Leading haptic better look like a number 7. So we'll deliver, deliver, deliver. Here it comes. There it is. And then optic comes out. And then we're going to dial it in and do an optic capture. And the lens looks like it sits fine. I don't see any vitreous. Everything was pretty good. Once I get the optic capture, if that goes great, then I'm happy. And we'll check with triamcinolone at the end here. Now I'm going to hydrate the incision first, because when I come out with the IA probe, I want to make sure I don't let the AC collapse. Because I can still get vitreous prolapse if there's none now. Here, I'll just use half my settings. Half the flow, half the vacuum, half the infusion pressure. Just take
slow motion fake.
Yes, exactly. Slow motion, take it easy. The video sped up, but I'm in slow motion. Microphone.
I prefer to close the pupil, and after that I put the IA to remove the visco.
Bring the pupil down first. Yes, probably a smarter idea. There's a triamcinolone, nothing. So get lucky. Sometimes it's better to be lucky than good. And so here at the end, it looks pretty good. Would you put a stitch in or not? Yes. Okay. We put my call. We put. Okay. So here, what do you tell the patient post-op? It's your problem. You have bad anatomy and ugly protoplasm. Why did you move so much? The capsule is weak, so we use alternate lens. It should not have negative effect on your vision. Or D, good news is you never need YAG capsulotomy. What do you tell the patient? All of them? I think it's important not to blame the patient. Even though I don't think I did anything wrong, I'm trying to help the patient. I can't help it sometimes. The capsule's weak. But it's an unusual case, and again, that's why I wanted to present it, because this will happen to every surgeon. You just have to know, okay, what do I do here? But luckily, everything went well with the patient. Patient's quite happy, and then it's a reasonable case. So then we have, again, more cases coming up here. There's the timer on the bottom so you know where we are. Just a few more seconds. And we'll see what's our next case. All right, next case is...
Arriba tenemos traducción
simultánea. Any
simultánea.
audience questions? This one I put in a minute for audience questions. Oh yeah, translation up here. Any questions from the audience? Something.
¿Preguntas? ¿Alguna pregunta, chicos?
Oh, 7L rule means when you put in the 3-piece lens, or any lens, the leading haptic must look like a number 7, and the trailing haptic like letter L. 7L. That's how I remember. I didn't hear. What did it say?
The vacuum, when you are polishing the posterior capsule.
Oh, the parameters I used, it was low vacuum, but...
Change the parameters after the lesson for the posterior capsule.
When I did the capsule polishing? Let me get to it later. Unfortunately, I can't stop the video. So posterior polar cataract, we all see this and we all get a little bit worried. If you're a young surgeon and you see this and you're not worried, you need to study more. Because what's the problem here? Posterior polar, what's the problem? At the site of this opacity, the capsule is frankly, can be weak, fragile, or sometimes even absent. So we know this is a very high-risk case. And so it looks pretty easy, but what's the big problem here? I think the problem you have is you can do hydrodissection. If you do hydrodissection, you could pop that capsule right open. So important. I keep measuring to get a 5mm Rexus. I'm like Neto, 2.5 and 5 millimeters. When I do the Rexus, I know I want it to be 5 millimeters because there's a good chance that I may need to put in a sulcus lens and optic capture. So you measure 5 millimeters. This is the paper Osher published many years ago, 35 years ago. He says it's 1/3 patients, 1 out of 3, 30% capsule rupture. So what's the most risky? Is it capsule Rexus, hydrodissection, delineation, nuclear fractus? So we said it for sure. The answer is B, it's hydrodissection. You can still do a hydrodelineation. Some people do hydrodissection, but only a partial wave. The problem is when the wave goes across the posterior polar opacity. But if you do just a little bit of hydrodissection, you can do it. I'm just afraid to. The other person who published the paper was Uday Vasavada, who also at the same time published a very similar paper with 33% capsule breakage rate. But I think since then, since we've learned how to do these cases, it's a lower rate. For you, Gid, for our panel here, in your experience, your hands, what's the capsule rupture rate in this case? Microphone.
Okay, nowadays I do my technique in which I do a mechanical cortical cleaving of the cortex. And
With the chopper?
Yeah, with the chopper. And it's, I would say, about less than 5%.
Yeah.
Yes. If you take care, if you know in advance what not to do, you get well. And I think you pointed it very well. It's absolutely important for you to have a nice centered and sighted capsular axis.
Yeah.
So this is your plan B if something untoward happens.
sure.
Neto, would you do the spin technique in this case?
No, just the cortical cleaving, and as soon as I notice that the nucleus mass is released, that's it. Then I aspirate the nucleus. Thankfully, these cataracts are usually very soft.
Yes.
So
Younger patients.
Yes, only require aspiration, and the down rotation for the central point is in equations has adherences for the capsule posterior.
Yeah, so Neto's technique is quite brilliant. Uses his chopper to go around the lens bag equator to just mechanically separate the lens from the capsule.
Uday, also the visco dissection is a good option.
Viscodissection is a great option. In fact, that's what I'm going to end up doing. I agree with you 100%. So here, I'm just getting the endonucleus out of the bag. So I leave the epinuclear shell, leave the cortex, get the endonucleus only, and then I'm going to take your advice. I'm going to do viscodissection with a dispersive viscoelastic in all 4 quadrants, and that's going to help me really get this out. Now here, I got to be very careful about coming out of the eye. So again, the endonucleus is now out of the eye. Now do you want to use IA to remove cortex, bimanual IA over cortex, viscodissection, or now you do hydrodissection?
Maybe C.
Yeah, so I agree with you here. Viscodissection, as we say, right, viscoelastic is cheaper than vitreous. So I don't mind using plenty of viscoelastic. Sometimes my nurse will say, "You want another viscoelastic? Doctor, you know that's $80. I'm like, believe me, it's cheaper than vitreous. 100%, right? You're a nurse too, huh? But what's
In this case, he used viscoelastic.
I think in a case like this, use as much as you want. So what's going to be your technique for the viscodissection? You're going to go in different quadrant? How will you do it?
I prefer quadrants. I put the visco in the 4 quadrants. I'm trying to avoid the cataract,
Yeah.
the posterior. Yeah.
So go on the sides.
Yeah.
Hey, Neto.
would you take care to empty the anterior chamber just a little bit so not to overpressure the...
Oh,
the-
don't
yeah?
overpressurize it.
Yeah.
Yeah, that's smart.
When doing the viscodissection.
I think also the femto is good for these cases
Why do you like the femto?
because we cut in the little piece, the quadrant, and you take the quadrant and you conserve the posterior part of the...
It's smart. So you'll use the femto to fragment the nucleus into pieces, and you can just take them out without any hydrodissection.
Yeah, capsular bag must be in the place
Yes,
to prevent collapse.
Right.
We have to prevent the collapse.
right. So here I'm doing your advice in quadrants, little bit by little bit. And Neto's right, don't overpressurize the eye, so make sure you burp a little viscoelastic out. And so once we get into 4 quadrants, it's actually pretty easy now. Now I can just use the IA probe and remove all this, and it should be pretty good. But even in this, I agree with Neto. I think in my hands, it's less than 5% risk now, but it's not 1%, it's not 0. And so what I do is be very careful. Every time that white polar opacity comes up, I always look back there very carefully to make sure. Let me see what's going on. The same thing here, taking this out. I'm going to be very careful, and let's just see, because sometimes you just can't help it. Sometimes you get bad luck. A veces mala suerte. Yeah, and now the other thing too is when this comes up, so I want to look back here, And now it's all, I already see like there's a, I worry, what is that? Am I in trouble? Look, now what? Should I worry? No. Woo, got lucky, baby. Very. Now, should I get this or don't worry about it? Should I polish the capsule?
Never.
Please, no.
Yeah, I agree. And then it's okay. Do you polish the capsule? D, you will be crazy to touch the capsule. Probably that's what I think. But I agree with you here. I've learned my lesson on the first case and yesterday. Let's not polish the capsule too much. We can use the YAG laser another time.
Even hydro polish is dangerous in these cases.
Yeah, even hydropolish is dangerous for sure. Because you think, the histologic studies show, right, a normal posterior capsule is only 4 microns. Just remember, one red blood cell diameter, 7.5 microns. So the posterior capsule normally is 4. And this, it can be 3 or 2 or 1 or 0. So you have to be very careful. So I agree, don't touch it at all. In fact, also, don't let the bag collapse. When you come out of the eye now with the eye probe, with the other hand, inject the viscoelastic to fill the bag. Because if you let the bag collapse or come forwards, it can split again.
I think this letting the anterior chamber and the back collapse is one of the major causes of PCR in these cases.
Yes.
Not during nucleus or cortex management, but that the surgeon say it's over, okay, everything is easy now, and then it just like when takes the probe out of the eye, you have the rupture.
It's right open. I agree with you there. So yeah, you got to be very, very careful. And even when you put the lens in, don't let the lens touch the posterior capsule. So here, injecting viscoelastic to fill the bag cohesive, not too much, just enough to fill it. Now I can come out with the probe. And for the lens, what do you want to do here for the lens? Single piece in the bag, normal?
Single piece in the back, yeah.
As usual.
As usual. So I agree. The difference, so single piece in the bag you like. Would you also put a CTR?
No.
No, that's right. Would you put, what about 3-piece lens? Not needed here?
No needed.
Not needed. So how do you deliver the single piece in the bag? How will you do it?
In the anterior chamber and going down. Slowly.
Also put in the AC and then position it down.
Yeah.
Don't like inject towards the posterior capsule. Yeah, if you're gonna, I'll put it in the bag, but I'll be very careful as I put the lens in to get it just under the distal rexus. I don't want the lens at all to touch the posterior capsule. So, but I like your idea. Put it in the anterior chamber, and then just tuck each haptic in by itself, and then gently push the lens posterior. I think that'll work really well here. But so these patients, what are the challenge though? Let's say this patient has a lot of astigmatism. You need a toric lens, and now the capsule breaks. Now what do you do?
Excimer laser.
Yeah, it's probably the best bet. On a case like that, I agree with you. I'll actually choose a higher IOL power, make them myopic, and then do LASIK or PRK afterwards. I don't want to choose the same IOL power because I don't want them to have mixed astigmatism. I don't want them to be +1, -2 at 90. That's a very hard ablation for laser. I'd rather them be plano -2 at 90. That's an easy ablation for the laser. So I'll increase the IOL power by a little bit, and then I can do the laser afterwards. So here we're going to put the lens in. Looks like a preloaded single piece under there, again, and that one. And I just want as little manipulation as possible. Should I still go behind? Oh, 27, even hyperopic eye. Should I still, I'm going to hydrate this so I don't let it collapse. Like Neto says, you can come out with the eye probe, you think the case is done, and the capsule will split. So here, I'll be very careful, but before I come out, with the left hand, let me inject BSS. Yeah, don't let it collapse at all. And this patient can have a nice outcome here. They tend to get PCO though, I noticed, because you can never clean the capsule well enough, so they get PCO. So now, questions for posterior polar from the audience, anyone?
Preguntas. Hugo, ¿alguien quiere hacer alguna pregunta? Uday, what about the scar of the posterior, of this type of cataracts?
The PCO?
Yeah.
They're gonna get PCO for sure. So when this one, I'll wait like 3 months before I do the YAG. In an average eye, maybe only 4 or 6 weeks, then I can YAG it. Here, I'll wait 3 months.
Would you do it I think that's what was asked. Would you do a posterior rexis
No.
if the capsule has like a significant opacity that you can clean?
I'm afraid
Like,
to.
no? Yeah.
Will you do posterior? You?
No, no.
I won't touch it. I'm afraid. I don't want any grief. I can always do a YAG laser. Of course, the patient will complain with a large opacity floating in the vitreous, but it's okay. All right, okay, here's a good one. Tennis ball to the eye. It's a resident case, so young surgeon. And what do we notice here? Wow. Now you can see the resident put toric lens marks. That's very wishful thinking. So what's going to be the big challenge here, right? The question is, do you already have vitreous prolapse? Maybe, maybe not. It's not too much of an area, maybe 3 clock hours. So here, doing an incision. This case is, okay, what did you see? Obviously, we saw this 3 clock hours, 1 quadrant of zyno loss. When the resident shallowed the anterior chamber, then you saw it even more. You could see the lens bag equator. It seemed like a routine case, and then, okay, I didn't see anything, I was on my phone. But obviously, in a case like this, that's the big challenge. The patient got injured 1 year ago, also has traumatic mydriasis. So the pupil has been 8 millimeters for 1 year, not responsive to anything. Pilocarpine, nothing brings the pupil down. And so we got to fix this patient here. This is about a 1 hour case for a resident. So just so you know, we edit the video, it looks so fast, looks so easy. No, it's 1 hour. And this is with a retrobulbar block and intravenous midazolam for sedation for the patient. Because this does take a lot longer than you think. If you're a young doctor, put this as the last case of the day, not the first case. That way you can take your time and not rush. So here's what we're going to do here. You can see there. Now, surprisingly, it's easy enough to get a rhexis done here. So the resident does a good rhexis. The question is, should you put a capsule hook in now to support it, or do you not need it? What do you guys think?
It will be a good idea, only one maybe.
One capsule hook would have probably been a good idea. Because now you can see there's the bag equator again, and every time we do this, we may risk bringing vitreous forwards. So maybe one capsule hook here would have been helpful. But I like the nucleus out of the bag. It's not too much of a cataract, it's not very dense. And so the resident can remove the cataract pretty easily here. The key, though, you have to keep in mind, as you do this, you can get infusion from the phaco going through the zonulopathy and collecting fluid in Berger's space. So here at the end, nucleus is out, but you can see that one hook would have been helpful because now look, you keep seeing the bag equator here. That's a problem. Yeah, right. So bimanual IA, I think, is very helpful here. And then the question is, well, when do you put in the CTR? We're going to definitely put a CTR, but when?
I think it's very beneficial to put it before doing cortex management.
Yeah.
It's usually the time that you perceive that you need it, but by then you have already pulled the equator and vitreous may prolapse, and so at the beginning is better. I think as we get more experience, we tend to put the CTR earlier.
Yes, I agree with you. So here we put a little triamcinolone, and look, you're right there. What's that? So I think here, what's the next step? Would you do the vitrectomy now? Because there is a little bit of vitreous prolapse. Don't worry about it, just insert the lens. Insert CTR now, or if you're a resident, you want to do Yamane. Let's take the bag out.
CTR. CTR.
Why not do a vitrectomy right now? You saw a little bit of vitreous. Why not do it now?
It's not too much vitreous. Maybe I will put the CTR first, and then put the triamcinolone and wait.
Yes, I think that we need to conserve the sonula now and the capsular bag, because if we start to do the vitrectomy, maybe with traction more vitreous and broken more sonula.
Absolutely, yeah. You want to stabilize the bag first. So CTR, I like answer C, CTR first to stabilize the bag, because if I start doing vitrectomy and the bag is moving all around, I may get more vitreous, like you said. I also may damage the bag. So I think right now is a good time to put the CTR, and I agree with Neto. As I get older, I like to put the CTR earlier. When you're young, you think, no, I'll put the CTR as late as possible because it's easier to remove cortex with a CTR. But then you realize, I'd rather have the stability, and even if it takes more effort to do tangential cortex removal, I think it'll be better for the patient. So I agree. In retrospect, maybe been better to put the CTR in before cortex removal. So here comes the CTR. I like using an injector. Here, the resident's just going to put it in with forceps, and you'll see it go all the way around. And make sure that goes totally in the bag. There it is. And now it's pretty good. So here comes the lens. Would you just put it in the bag? Or you want to do optic capture, sulcus haptics? What would you do here? In the bag?
In the back, yeah, yes.
Let's take a look. I think here we're going to do it optic capture. So the zonulopathy is here, so maybe put the haptics 90 degrees away. So here we go, get that inside, rotate it around. But this is a pretty good case for a resident. This resident has done maybe 200 phacos and maybe 2 M6 only. So pretty good for this level. Now there's still a bit of vitreous here. We're going to need to get that out. So there's the vitreous. How do you want to get that out? Should I set up the vitrector? Should I do a pars plana trocar, all this?
It's too much.
Too much. And here we're pulling the iris to see what we can get. There's that one strand. I think, can I just cut it with scissors?
Myocol and scissors.
Yeah, you're right. That's what we're going to do here. Now, myocol doesn't work because the patient has this traumatic mydriasis. But yeah, just cut, with scissors, just cut. That's it. I think it'll be fine. And we'll
Nice
check
and
again. Yeah? But so how are you going to fix the mydriasis? A, it's not so bad, give sunglasses. B, this is reasonable. Come back another day to fix it. C, refer to another surgeon. Or D, perform pupiloplasty. What would you do here?
If you have time and you have a good anesthesia, maybe a pupilloplasty can be performed here.
Yeah, this is the last patient of your day. You got good anesthesia, you did a retrobulbar block, you have time. So maybe
I think it's D. D is a good option.
And how do you do it? Do you like pupil cerclage, purse string?
In my experience, the pupil cerclage is very difficult.
Yes.
I prefer the four-through technique from Amar Agarwal. It's very easy.
I agree with you. Neto, what do you do here?
Cerclage is very difficult. It's very difficult.
I think, well, pulling the iris may give you an idea of how much you should be able to do a pupil cerclage, but it's very difficult. I think only ICAMED can do it
It's
like
very
he
difficult.
shows. I don't know. I have never been able to do it. But I think with two stitches, two sutures, sometimes it's okay. You got like from the border to the center, and you are able to give it's important to do a pupilloplasty in this patient now or later, because it will enhance optical quality.
Yes, for
definitely.
Sure. Your fellow, Guilherme, sent me a video of a cerclage. Beautiful job. I wish he was in Los Angeles. I'll send him all the patients. Have fun. Disfruta. So here, I'm going to do what you said. This is just Agarwal's technique, fourth row pupilloplasty. Cerclage is going to be too much work. Here, the resident who's never done iris suturing ever, first time ever doing pupilloplasty, is going to do this. So this is a 10-0 polypropylene on the long needle. So again, you pull it through here, through the paracentesis, and then it's 4 loops. 1, 2, 3, 4. And then you can tighten it down. That's Agarwal's fourth row pupilloplasty. And there's 3 hands here. This is me teaching, and this is the resident suturing. We're doing a good job, really good job. And now we can pull the knot, and the knot will go inside the eye, and you'll see it looks pretty good. Now, a few important things. Make sure you get enough iris tissue. If you do the very, very edge of the pupil margin, you can pull the suture through the tissue. So you got to get a good bite. Here's one suture, and sometimes it takes, like you said, it takes more than 1 suture. It may take 2 or 3 or 4. I think in this one they're going to do 3 sutures. So there's 1 suture, it's looking better. What's your ideal pupil size? How small to make it? 3 millimeters, 4, 5, 2?
4, 5, 4. Maybe 4 or 5 millimeters.
Yeah, I think that's reasonable. I always think you want to be able to examine the retina. So if I make it too small, you're not going to be able to do that easily. So I think somewhere about 4 millimeters is reasonable, 3.5, anywhere in this range is okay. I want it to look normal at conversation distance. So like 60, 70, 80 centimeters away, when I look at the person, it should look pretty normal. That's the goal. And you can see here, it looks pretty good. We'll take it. Here at the end is bimanual IA, suture the main incision. It's a pretty nice result for the patient. Patient's pretty happy. And so that's a really good looking result for this patient. And definitely, if you're a young surgeon, you can do a case like this. Just give yourself plenty of time. Any audience questions for this? Yes? So most cases that we do, we teach our residents to sit temporal to do phaco. And in my own private clinic, 99% of the time, I also sit temporal. I make the phaco incisions temporal. I know most people like here are sitting superior. The reason we like temporal is the temporal limbus is farthest away from the visual axis and least astigmatic effect of the incisions. Plus, it's very easy access. Even if I have a patient with a very large brow or deep-set eyes, so easy to get to access temporal. Now, the advantage of superior is it's covered up by the eyelid, so the eyelid is going to protect it. But for us,
superior, you don't have to move in the right eye and in the left eye.
Correct.
You're always in the same place.
right? It's correct. So I like, me personally, I like to operate temporal. I always operate temporal. When I teach the residents, they sit temporal, I sit superior. All right, now plenty of experience here with another one, a brunescent cataract. Let me show you something a little different here. You will think I'm a little bit crazy, but let me show you anyway. So old video from 6 years ago. So put in some trypan blue dye, maybe a little bit too much dye, but that's okay. There's no zonulopathy, it will be okay. So let's put in viscoelastic, and you can see it's a very, very dense cataract. So in a dense cataract like this, what is your way of doing it? We're gonna do phaco. We're not doing M6 here, this is phaco. So first thing is, make a big rhexis. You agree?
Yeah, that's the key.
A big rhexis. And now, how do you want to do? Who says divide and conquer? Who's going to do stop and chop or some other kind of chop? Bianchi, you want femto? You want lens loop, lens snare? Or you want to pull it out of the bag and crack the posterior plate?
B or D?
Maybe
I
B,
prefer
B.
B. I
B.
prefer B.
B.
Yeah.
Everyone agrees?
For this case,
Yeah, I think maybe it's advisable for the surgeon to do the technique that he or she is more.
What's good in your hands?
Yes, because this is a challenging case, and make sure you're protecting the endothelium and refill the anterior chamber whenever needed. You will get by with many different techniques. So,
Right.
yes, not at the time to try a different thing that you're not used to.
But one of the challenges is, right, the posterior plate of the nucleus can become very dense and fibrous.
The femtolaser
Helps?
helps a lot in this case because it's some pre-cutting, and I do the femtosecond in this case when I don't want to do the M6. I do the femtol, and it's very good because it's pre-cutting and it's easy to cut, and we don't have this posterior. Yes,
It helps a lot
posterior blade.
to-
It's very good for me, and also in cataract like this, I have some presentation, and it's so good.
Well, I'm gonna do something crazy. Watch this. I'll show you. You'll be surprised. I want to get this out of the bag. It's not a small eye. It's an average eye. So I'll do a little bit of hydrodissection here, but I want to get to that posterior plate. So what I'm gonna do is, you're gonna think I'm crazy.
downside.
Okay, it rotates. That's why I should spin it more. I want to get that posterior plate. Let me just do this. Let me put the chopper here.
Downside
Oh,
up,
baby.
Downside up.
Now you think, look at that. There's the posterior plate. Right there, I can get it now. Now I can trap the nucleus between the chopper and the phaco probe, trapped there, and I can put my weightlifting muscles to use and split that thing. You think crazy, huh?
Yeah. What about the endothelium?
It'll be okay, we use viscoelastic.
In these cases, I do like a small groove just to be
Very.
sure that I am very deep in the hard nucleus. So when I chop it, it will divide it.
Look at that thing. Finally get it. But like Neto says, you can recoat the endothelium with viscoelastic. Just take your time here. But at least I access that dense posterior plate. And I can chop, chop, chop. And I'm operating not in the AC, I'm at the iris plane. So a little bit more anterior.
A good case for a DMEC.
Okay, maybe. Listen, I gotta show you something unusual here. I can't show you boring cases. We have to have some excitement. But we get it done. If you need to recoat endothelium, fine. This patient did have corneal edema on post-op day 1, but it
In any moment,
resolves.
collect more viscoelastic in the phaco.
Yeah, you can.
You
You,
what?
you can do
Put-
little
put more-
phaco
more-
and then viscoelastic, more phaco, more viscoelastic.
Okay, that's right.
But even then, the truth is this patient did have some corneal edema post-op day 1, but after a couple weeks it resolves. But even if the big rexes is the key, especially if you're gonna do what I did and bring it out of the bag. So if you're gonna do, I guess here it's different, because in the USA, they don't do M6 at all. Very rare. So the USA, unfortunately, they do traditional extra cap with the corneal scleral scissors. You should definitely not enlarge a corneal phaco incision. You should not push it back into the vitreous cavity, but you should, I think, definitely perform M6. So here in Argentina, what's the training? So residents will first do M6 before phaco?
Years ago, residents were trained first with extra cap and then phaco. No M6. M6 is not so popular here.
But now the young doctors were saying they're learning it.
Yeah.
Any
Now-
young doctors?
yeah,
Who's
yeah.
learning M6 in residency? Anyone? No young doctors? You guys didn't learn M6? Don't be shy. Muy tímida.
It's a good option in this case.
No? Majo, you do the M6, come on. Of course she does. She does more than I do.
It's good, but we don't have a lot of cataract like that to teach to the resident to do that.
Okay. Oh, you don't have a lot of brunescent cataract?
Californian cataract.
For you? This is Beverly Hills. I still have it. This is Beverly Hills. Don't worry. This is a very difficult case, obviously, but I think M6 is definitely the thing to learn. And I got some great advice yesterday from you teaching me some good M6 pearls. So here we go. Here's how I teach M6. If you haven't done it, here's my way of learning it. And I do it a little bit differently than I was taught. So obviously, good anesthesia is key. So retrobulbar anesthesia, I think, is ideal. Peribulbar if you want, or subtenons. You got to do a big peritomy. Do some cautery here. Maybe a little bit too much cautery. And then the key is the way the incision is made. So half scleral depth, and then it's got to be a trapezoid. And the key is you want to have a long shelf. From here to here has to be long. And so as we're doing this, we'll see, again, half scleral depth. This patient's actually very, very myopic. And so you'll see it's a thinner sclera than most. And so you can even see the blade there. That's half scleral depth. And then we get, again, trapezoid shape. You really want to make this bigger than you think. What do you think? And then here we can get the trypan blue dye out and stain it nicely. And in a case like this, again, like we were saying earlier, make sure you get a big rexus, because you got to get the whole nucleus out of the bag here. So here we're going to make the main incision. I'll put the diamond in there. I like to do the rexus through just a small 2-point-something millimeter incision, but you definitely want at least 5 millimeters, 5.5. Even if it's 6, even if it's bigger than the optic, I don't mind. Just do something big. But here I'm going to try to aim it for about 5.5. It looks super big, but I'll show you at the end, it's definitely going to overlap the optic 360. So there you go. It's a very dense cataract. And then now, once you do that, you get it out of the bag, a little hydrodissection. But really, the key is to just rotate it and get it out of the bag completely. I want the nucleus on top of the lens capsule, on top of the iris. And so once we get this here, there we go, slowly bringing it up. And again, remember, my total lifetime M6 is 300 cases. So I'm no expert, but we all learn together. So here, more viscoelastic in front and behind to push the capsule away, in front to protect the endothelium. And then here's the trick I do. Once we enlarge this, make sure you really get it wider than you think. You don't want to suffer. I make an opposite para. And the reason is I can then just push it out. A great surgeon will actually, an M6 surgeon who's a great surgeon, can do it just viscoelastic and the way they move it. And I learned yesterday from a colleague here that I shouldn't just pull straight out, I should pull, and then here, pull downwards. So we're not quite doing it, but I'm just using the spatula to push it out. There. And now we get the whole thing out. And it looks like it's a boy. And here at the end, again, I like sutures to close it. I think it's just a lot less stress if I put the sutures in. And then here, I tend to put the sutures in, but I tend now to do bimanual IA. I think is better. Here, if I try coaxial IA, which I'll do here, the problem with coaxial is the incision leaks too much, and I'll get a little bit of iris prolapse here. So I put 2 sutures in, put them about 3 millimeters apart, We can tie these up. And by the way, if you're a young doctor, you know, my test for suturing is a young surgeon, if you can do 10 sutures of 10-0 nylon in 10 minutes in the wet lab, you're very good. So that's the test, 10, 10, 10. So here doing a little bit of cortex removal just with coaxial, but you see there's a little bit of iris prolapse there. So probably better now I do a bimanual IA cortex removal to get that out. And then here at the end, we'll put the lens in the eye. Here's the viscoelastic. This is a 3-piece lens because it's a very, very low dioptric power, not available in single piece for me. And so here comes the lens, so delivering it. There's a 7L rule, 7 like that haptic, this one looks like L. And so then, and you can see there's an overlap of the rexes. It's not that big, it's probably 5.5, but there's some overlap. And then we close this up and the patient can have a good outcome. So I think very important to learn how to do this. Any questions from the audience about M6 or in this case? No? I see all the young doctors with no gray hair. Come on. I think it's, yeah, I think M6 is, I use it about once a month, even in Beverly Hills.
I think it's very important to stimulate the surgeons, the beginner surgeons to do it, because they will get amazed at the post-op day one.
Yes.
No corneal edema at all, and a beautiful eye. So I think for very hard cataracts, that's the way to go. Definitely. So.
And I think it's important to plan before these cases, so you have enough time, because phaco maybe it will take you 10 minutes, but this will maybe take you half an hour.
For sure.
For doing.
For sure. Even in my schedule, when I book M6, I book it for 2 spots. So phaco, 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 and then M6 will take 2 spots. Okay, now look at this. Floppy iris. This is me operating, so I'm going to be doing a bad job as usual. Let me make a big rexus here, nice rexus. And so patient takes Flomax, tamsulosin. We talked about floppy iris yesterday. We don't like floppy. Too much stress. So look what happens. What am I doing wrong here? Hydrodissection, and now look what happens. Look at the incision. Look, look, look. And now look, 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 look. What's going to happen?
Yeah.
Oh. So what's the next move? What do I do now? Who says push the iris back in the eye? B, more viscoelastic. C, release trap BSS. D, pars plana tap to alleviate pressure. What do you think?
Yeah, you have to lower the pressure. You have to
C.
lower the pressure.
Tell me, how would you do this? I put too much BSS. So, okay, from the Pero, what would you do here? What do you want to do?
Maybe get out some vascuelastic.
Yeah, you got to equalize the pressure. I think for sure the answer is C. I injected way too much BSS. Why? I don't know. But I think the way to solve it is you have to release where's the trap BSS. I don't think don't push on the iris, you'll damage it, right? Neto says you can go to the Pero, that's helpful also. Be very careful about injecting more viscoelastic because you're just going to cause more issues. I think putting more viscoelastic does not fix the problem. The problem is too much BSS trapped. There's too much BSS behind the iris, so it pushes the iris out of the eye. So what I'll do is I'll just release the trapped BSS just with that same cannula. I'm going to lift the nucleus a little bit out of the bag. It'll release the trapped BSS, and the pressure will be equalized, and the iris prolapse will be fixed instantly. Let me show you how I do this here. And so luckily I'm fixing my own mistake. Here we go. So there it comes out again, and I just look, done. So I'll slow it down. Let me show you that again. Yeah, so you can actually fix this quite easily by getting that fluid out. Here, now I am using the iris to hold the nucleus for me, and now we can just chop it and finish the case pretty easily. So I often like to use this technique and have the nucleus held in place by the iris. So go right there, boom. Let me show you again slow motion. So here comes the BSS. Viscoelastic comes out of the eye, iris comes out of the eye. There's too much BSS here, so I'll push the nucleus and lift this way. Release the BSS, look, right here. There, BSS released, and then the iris goes back in the eye. So it's solved very easily here. And so again, let me show you one last time. There it is, fix this, there, it goes back in. So here's another case, very similar.
In these cases, you can put a maluyin ring from the beginning, and you will not suffer.
That's probably a smarter idea than what I'm doing. He says, put a Malugan ring at the beginning so you don't have to suffer. So here's another one. Would you inject more agents? Can you inject, does this help in the eye? Epinephrine, phenylephrine, does that help at all?
Yeah.
You say use expansion ring right away. How about pupil stretching? Do you like to do pupil stretching ever? No, why?
No.
It'll become worse?
Yeah, maybe.
I think in floppy iris, if you stretch the pupil, it can become worse. But I think if it's just small pupil from like pseudoexfoliation, which is not necessarily floppy, I think a pupil stretching actually works well. Do you ever do pupil stretching, Neto?
I usually use a pupil expander. I prefer, and then you must assess if the pupil is elastic or rigid. If it's rigid, you must, before inserting the pupil expander, you must make it elastic, either taking out fibrosis, pupil margin fibrosis, and everything. But I rather use a pupil expander than stretching it.
That's actually a great point.
But also, it's very important to do an incision much more longer to
Longer.
avoid the iris prolapse.
Oh, more anterior and
Yeah.
longer tunnel length.
Yeah, the incision must be more longer.
That's a very smart idea. Because, yeah, if you do a short tunnel or more posterior incision, you're going to have more iris prolapse for sure. But yeah, differentiating between is it a stretch or elastic iris, or is it rigid or stiff iris? That's important. Well, you're not going to like me because I'm just going to stretch the pupil. I'm just going to use 2 choppers. You know, I can't make you happy. I got to give you a little controversy here.
You like Tuffer.
So we'll stretch the pupil a little bit. That looks pretty good. No? He's shaking his head. Okay. He says these California doctors are poco loco, huh? So there's a good pupil. Now it's a good pupil size. Now we'll get our rexes done. Too much of a cowboy? California cowboy? All right, well, we're still getting it done. Now, I can make the rexes even bigger than the pupil. That's okay. You know where it is. So make a bigger rexes than the pupil. And now we'll do some hydrodissection. Get the bubble out. Here's the hydrodissection. And I want the nucleus partially prolapsed up. I want the nucleus to hold the pupil open for me. There you go. Something different. He's shaking his head like, oh my God, you're crazy. Too crazy. It would be easier to put the Malugan ring, huh?
You don't like the endothelium.
I love endothelium. So we chop it here. Boom, look at this. 2 halves, and we're done. Okay, now here I agree with you. I make a paracentesis. I'm sitting superior, by the way, on the steep axis for the astigmatism. And as soon as I do a little bit of BSS in the eye, look. Actually, that was lidocaine in the eye. Already. So you know what? If this happens, I know, even me, I'm putting in a pupil expansion ring. I think A is not going to do anything. B is the correct answer, pupil expansion ring, or if you like, iris hooks. Pupil stretching, oh, that's already going to become worse. And I don't just plow ahead. I think you got to take your time and plan this out. But that's my clue.
One tip when with floppy iris and when doing the hydro, to avoid iris prolapse, you can put a phaco sleeve around your cannula, so that will occlude the incision. Of course, you have to lower to empty the anterior chamber from visco so that you have space. And this usually prevents and makes it easier for you to have a nice hydro, because when the iris begin to prolapse, you usually stop the hydro, and then you weren't able to do a nice hydro. So this is a useful
That's
tip.
a great idea.
Yeah.
I love that. We have a video of that on Cataract Coach, which is putting the BSS cannula
That's a great
inside
idea.
an empty phaco sleeve. So here, I'm going to put a viscoelastic. I'll get the iris back in, and I'm going to put a little bit, lift up the iris in a few quadrants with the viscoelastic so I can put the Malugan ring in. So here we'll use a Malugan ring. Again, lifting a little bit of lifting the pupil up, the iris, with the viscoelastic. Here comes the main incision. And then we'll put the ring in, and usually we can get the whole ring in at once. So here's leading one, here come the side scrolls, and you can lift the iris if you need to get it in where you, there it is. And you
Wonderful.
get, even the trailing one all done, boom. So we'll get that done. Now, obviously the case is gonna be a lot easier. Here we'll chop in the bag. We'll respect the corneal endothelium. There's the lens in. And now I like to take out the ring while the eye is full of viscoelastic. It's easier, I think. So I just disinsert the ring, and then I'll just use the injector. Oh, astigmatism, so I'll do a paired incision. Sometimes we can do that for a small degree of astigmatism, 0.5, 0.6, 0.7 diopters. So here we go, get the ring off, and then I like to just grab it with the injector. And so I can use the same injector, grab anywhere, and then just whoop, take it out. Boom, out you go. And I still like to remove viscosity from behind the optic. And again, patient can have a nice outcome here. Sometimes though, we get unlucky. Look at this case here. What will you do here? Patient had surgery a year ago, and now seeing you. How will you fix this? Can you suture this defect? Yes or no? Do you do nothing and blame the patient for having bad tissue? Cosmetic contact lens, pupilloplasty, or refer for prosthetic iris. What can you think here?
Pupilloplasty.
You can do it, huh? How many clock hours can you do? 1 clock hour, 2, 3? How many can you suture? 2 maybe? 3 maybe? Sometimes more? How about you guys? You do pupilloplasty too? How many clock hours can you do? This is not too bad. This should be okay. But the challenge is blue eyes.
Yeah. Maybe you can start with one, and then you can do 1 or 2 more if you need it, but you can start with one.
That's a good idea. And then suture for this, you're using 10-0 polypropylene then?
Yeah.
The typical?
Yeah.
That long CIF4 needle? Okay, so we'll do that. I think in this case, you'll see it looks pretty good, but you have to be careful. Here's why. Let me show you in this case. So as we do it, we'll put the suture in here. Make sure you grab enough tissue. So grabbing the other end, bringing this out, and then when you get this and you tie it up, look carefully. As you pull on the iris, you're going to cause other holes to form here. So this iris tissue is so delicate, especially with a blue-eyed patient. I like the brown irises, they're tougher, they're thicker. But when we tie this up, you'll look, it looks pretty good. And it's okay, not too bad. Maybe a couple more sutures will do it. But look, as we do this, you're getting more holes in the iris. Those are not peripheral iridotomies. You're causing holes when you pull on the iris tissue too much. And we've lost the pigment from behind it, so it may not function quite the same way. This will give better function to a degree. It'll give a little bit better cosmesis or cosmetic effect. But yeah, as we're doing this, you can see there's a couple of, you're tearing holes in the iris root here. But I think 2, 3 sutures will probably do it. And again, it looks pretty normal. And I'll show you the patient from conversation distance. Will look okay, will look pretty good. But remember, this happens to every surgeon. 100% of us in this room have had a patient with iris damage from phaco. This is the nature of doing our surgery. So at the end here, looks pretty good. 3 sutures there, 10-0. But look at the additional holes now. So there's a post-op, looks pretty good. And if you compare to the other eye, that's not too bad. That's pretty good, pretty reasonable. So patient's happy. Not perfect, but pretty good. All right, any audience questions or comments from you guys?
¿Alguna pregunta?
No, muy tímida.
Juan Carlos, ¿alguna pregunta? What happens if you have a superior iris defect?
Hopefully the patient has ptosis, you don't worry. I don't know.
You fix it?
You can, I think you can, but if the patient has ptosis with, old patients, then maybe you're okay. Maybe you don't have to worry about it.
The good thing is that you often get amazed by the result of your rhinoplasty, because you usually think, I will not be able to do it, and then you are able, and the result is spectacular. So I think for beginner surgeons, you should do it. You should do it. Sometimes not on the same surgery that you're doing.
Okay
if
to
you
come
have,
back.
in a surgery, but definitely you should try.
I think it's for sure. For a young surgeon, you should try all these things. So we talked about this one yesterday. I even met Dr. Ariel Blanco, my friend. So in this one, I think his idea was smarter than mine. Don't make a paracentesis, he says. Just poke in with the needle directly without making a paracentesis. And then I think you'll be a better result here. But again, needle decompression, we talked about yesterday, the Blanco technique. You could use Zepto or Femto, or you could buzz the phaco probe. But I think the catch is to not do a regular rhexis. And go ahead, tell me.
Hey,
Hey,
here's
hey,
the compression.
So how
Blanco punción.
are you doing it? 27 gauge, 30 gauge? What do you do?
30.
30.
30.
27.
27. And then you have just 3cc syringe with BSS?
Yeah.
Make sure you try it outside the eye so it moves easy.
We have aspiration. We aspirate, we punch it, and we aspirate.
And you punch it in the center
In
of the
center,
nucleus?
in the center.
Or in the side?
In the center.
In the center.
Right in the center.
Yeah.
When you put the needle in, you go the bevel down then?
Bevel up.
Bevel up.
Yeah.
You say bevel up too, not bevel down.
I prefer bevel up.
I go bevel down, and also I tap the nucleus down a little so that the posterior, the liquid from the fluid from the posterior part of the equator comes out. Yeah.
Now this is an unusual case because this is a young patient. You've seen these before, right? This patient is maybe 30 years old, no trauma, just bad luck, comes to you with bilateral white cataracts, and there's almost no nuclear density.
This type of cataracts also sometimes has fibrosis, so with a femtosecond laser is not easy to do a good capsulorhexis.
Right. So here we're doing this puncture, but unfortunately this one is just too pressurized. As soon as we enter, it just splits. Now maybe the problem is the paracentesis instead of just poking into the limbus itself. And so here, you can still save this case, but again, this is always sad to watch. And you can see a young patient for sure, but it splits instantly.
The thing is that you have done another side port there. So
Yeah.
you shouldn't have that one.
So no side ports, yeah, just puncturing directly at the limbus without a paracentesis.
You have to do the punction without any incision previously.
Different pressures. Right. It's the pressures. It's about entering the eye with no other openings. So
Ariel Blanco is here.
Yes, for sure.
Come, Ariel. Come here.
El maestro.
Maybe he can teach us.
Here. Here, right here. Here comes some. Siéntese aquí.
Ahí está.
Teach us.
Yo le explicaba, hablo en español.
Claro, claro.
Yo te contaba ayer y te explicaba que el hecho de hacer ya una paracentesis para poner el viscoelástico o para poner el azul tripán ya cambia las presiones.
Okay.
Que la blancopunción está pensada en el mismo concepto del jack láser previo, es decir, con el ojo virgen, con el ojo estanco, con esas presiones originales, y no cuando uno ya le cambia las presiones, ya se cambió esa oportunidad única de tener, de poder equilibrar las presiones. Esa es la diferencia, porque eso que estás mostrando de ya la paracentesis hecha y es lo que veníamos haciendo siempre. La blancopunción cambia un concepto que es copiar al jack láser, de tener el ojo como primer acto quirúrgico, punzar directamente.
So la primera cosa. Antes de incisions.
Cuando las presiones se equilibran entre sí sin haber hecho ningún cambio, ni haber puesto viscoelástico, ni de más ni de menos, porque cuando uno ya pone el viscoelástico,
Cambia la presión.
cambia, o más o menos, pero cambia.
Yeah, for sure.
Ese es quizás el secreto, ¿no? El cambio del paradigma.
So, la primera cosa. Antes de todo.
Antes de todo. Todavía no está ni azul tripán, ni viscoelástico, ni paracentesis. Directamente una aguja que punza, no aspira, sino que punza solamente.
Punza, pero no aspira.
No aspira. Intercambia presiones al punzar.
Y antes de poner Trypan Blue.
Antes de todo.
Okay, wow, okay.
¿Ah? Punzo el centro, la retiro de la punción y espero unos segundos a ver qué pasa. Muchas veces no es productivo, es decir, no sale nada. Y bueno, me quedo tranquilo. Y si sale, sé que se está intercambiando la presión, sé que se está equilibrando. Y después hacer todos los pasos con cuidado, ¿no? Obviamente. Cuando hay aceite, cuando el paciente está con vitrectomía y aceite, esa presión positiva agregada me ha hecho hacer banderas. Sí. Solo con aceite. Y para eso se le ocurrió una vez a Gastón Gómez Caride poner un trocar hacer que el aceite suba por la vía del trocar, hacer todo el procedimiento, hacer la punción y todo, y después devolver ese aceite cuando termina el proceso.
So, la primera cosa es punción y no, sin aspirar.
Sin aspirar.
Y después necesita esperar 30 segundos.
No
dos,
tanto.
¿no?
Ir mirando, a veces en 10 segundos ya salió lo suficiente. Yo lo que vuelvo a hacer es volver a punzar para movilizar, por eso que has mostrado ayer del líquido que está atrás del núcleo. ¿Te acuerdas que mostraste ayer el líquido retronuclear? Para que salga ese líquido también. Volver a punzar y mover el núcleo con la punza.
Ahorita comprando. Antes no comprando. Antes el problema es, yo pienso que aguja con aspiración, pero es no blanco aspiración,
No.
es blanco punción.
Punción.
Esa es la diferencia. That's my mistake. So this case here is just double rexes. So one baby rexus to complete the case, and you can always, at the end of the case, with the lens in the bag, you can always enlarge the rexus. I think that's always very easy. You can always enlarge the rexus here. So here, once the lens is in the bag, very easy to go back and enlarge the rexus if you need to. So sometimes double rexus technique can be very, very helpful. And again, you can just grab it here and we'll be able to hopefully, maybe use a cystotome, nick the capsule, and we can make it a little bit bigger. You had any comment here? So now we heard from the boss himself, el jefe superior de Cataratas Blancas. Ariel, okay, perfect. So there you go. There's the second rexus, and again, nice outcome for the patient. Any audience questions for this, for white cataracts? Yes? Okay, okay.
In these cases, I would like to do anterior OCT to see the lens rise.
Yes.
So you
smart.
can know the pressure of the nucleus.
That's a very good point. Okay, this is one of my Beverly Hills patients. This is second eye. First eye had EDOF lens, patient's very happy. Wants the same for the second eye. Looks pretty routine case. Again, it's me operating right here. So normal case, good nucleus removal, everything's fine. And then we're gonna get a challenge here. We're gonna find out. As I'm taking out the nucleus, I noticed that the bag seems a little bit shallow. So it's okay, looks not too bad, except what happened there? I didn't even realize what happened there. So we got a bag equator visible right there. So what do you want to do now? CTR now, capsule hooks, caution proceed with cortex removal, or triamcinolone. What you will do now?
The CTR first.
CTR? Everyone to CTR? You don't need to put triamcinolone first to check? So you'll fill the bag with viscoelastic before putting CTR. Any tricks to fill the bag? Should I do visco dissection at the same time? Or not really needed? Just fill the bag. Same? Everyone?
CTR.
The CTR.
How about C? Just go ahead and proceed with cortex removal. And CTR later. That's the whole question.
You have to think in the security of the patient. If you go with the CTR first, the next steps, you will do it with more security.
Yes. So we're going to not listen to your advice because I'm not so smart. I got to give you some challenges here. So we'll take out the cortex. All looks pretty good. But this one area we know we're going to have an issue here. So we'll definitely put a CTR in. Don't worry. I'll put a CTR for sure. But now we'll clean this up, and then last I'll go to this area. But it's a very small area of zonulopathy. It wasn't a huge area, so I'm not super worried. And I think we can clean it up pretty nicely. But maybe here, I can give some counter traction. So to get the last bit of cortex, can you do bimanual now is better? Can you leave it? Or put the CTR now? Now put the CTR. Take the last bit. What about, can I use my chopper in one hand to support the capsule at the rexus, and the other hand take out the cortex? Can I do that?
You can do it.
But why would you?
But I'm not sure.
But why suffer?
It's risky.
Is expensive the CTR there?
CTR is about $100. Malugan ring is $125. Trypan blue dye is $66. So those are our prices. But no, the price doesn't matter. We want to do what's best for the patient here. But the question is, do I really need to? Okay, I'll put a CTR, but right away, or maybe not. So here, let me see what I'm doing here. I can't remember exactly. So we'll go ahead here. Let's see what we got. Okay, I'm going to use a spatula to give counter traction. He's shaking his head. He's like, yeesh, these California cowboys. Vaqueros, the California. Vaqueros, the Beverly Hills, baby. So there, the counter traction. I can get it out. And then now, okay, now let's put a CTR in. Put viscoelastic here. And we'll put a CTR. How do you like to put the CTR? You look to the injector, you do it manual?
Manual.
Manual. I like the injector. So we have these in the injector, and I like to put the Sinsky in the leading eyelid, like this, and I just find you can dial it in really nice and easy then. Like this, boom, and get it right there. Now I have a tough case coming up where I don't know the answer. I'm going to show you this another one coming after this.
Do you mind in which direction you leave the open portion of the CTR when putting in the dialysis?
Ideally, you want the open part not near the dialysis, but I'm not super critical, to be honest. And I don't even measure the CTR size. I just choose the middle one for everyone. Should I measure it? Should I did anyone here do different CTR sizes per patient? I just choose el medio, no más. So now it looks pretty good. All right. Now here's the case. Watch carefully because I don't know what the answer is, okay? I don't know the answer. I need your help. I do not know the answer. It's an anonymous surgeon who happens to be using my instruments in Beverly Hills, but anonymous, okay? I want to put a CTR here. So I'll put in some viscoelastic, fill the bag, cohesive viscoelastic, okay, good. And I'm going to put a CTR in. Oh no, the anonymous surgeon is going to put a CTR in. Now watch carefully. Tell me what happens here. I don't know the answer. Watch carefully. Watch. Ready? Okay, okay. Watch. Okay, okay, okay. Now what? Who? Tell me what happened? I don't know what happened. Tell me. I don't know. I'm crying here. Like my heart rate is like 180. Okay, what's the answer? CTR's in the bag, wrinkles are okay. CTR's ripped the bag, CTR caused more zonal loss. I have no idea. I don't know.
Maybe B.
Maybe
Average eye, 23 millimeter axial length, 20 diopter lens.
the viscoelastic was enough. Maybe it was we need to put more viscoelastic in the back.
I blame the patient. Siempre los problemas del paciente. Y no se mueva, mira la luz. Mantenga los dos ojos abiertos. Híjole. I don't know. What's the answer here? What happened? I don't know. I really don't know. All I know is now I am very, very nervous. The catecholamine release. Now my body has got a lot of epinephrine going. And I don't know what to do. What should I do here? I don't know.
You have to take it out.
Yeah, yes.
Leave it or put it,
Take it out.
reposition it, no?
No, because you don't know what happened.
That's why I'm asking you. Tell me what happened. You saw it.
I don't know.
I don't know either. Neto, you know. What happened? He doesn't know either.
I wouldn't take out the CTR, but the thing is that both ends didn't end in the same place. It's like one end is there and the other end is in very far away.
Okay, so it's out now. I put more viscoelastic. I don't know, man. Here, there it is. I'm going to show you. Let me show you again what I did here. So there it is in the eye, and I don't know I don't know. Maybe one armed in the sulcus, one's up. I don't know. I just want it out. I'm going to follow your advice. Get this out of there. Oof. Oof. I don't know. Then what's all the wrinkles here? Ahorita yo quiero llorar. No más. I want to cry. I don't know. Then what is this? What's that?
Dialysis.
Or Richard.
I don't know. I don't know. Okay, what should I do? Put the CTR back in the bag and now single piece in the bag. Put the CTR back in the bag and use a 3-piece in the sulcus, optic capture. Remove CTR and single piece in the bag. Remove CTR and 3-piece sulcus. What you do?
D.
Neto, you said D. Why D? No CTR then.
You might not know what happened to the back because there might be a rupture, but it seemed that like Andrés said, one side of the CTR was out and the other was in. So, but now you have some issue with the back. So
Yeah.
I think 3-piece in the sulcus and optic capture would do. I wouldn't risk putting an IOL in the bag now.
What are those wrinkles that were there? Germán, what's the wrinkles?
I think maybe we need to put more viscoelastic before to put the ring, the CTR. I don't know, maybe.
But now you agree with D. Put this, no CTR and 3-piece lens, yeah?
Yes, now yes.
But what happened in that one area with the wrinkles in the back? What is that? More OVD?
Yes.
It's on your dialysis? So I put more viscoelastic. I agree. I'm just putting the 3-piece lens in. I don't want to touch it anymore. I don't, maybe the bag ripped at the equator. We've had some CTRs where the manufacturing, the edge is not smooth, has a little bit of a plastic burr, and as you advance it, rip the, I don't know. So I'm just going to do what Neto said, what you guys said. I'm going to put 3-piece haptics and sulcus, optic capture. I just want to go home. I'm done with this case. I don't want it anymore. So I don't know what happened. I watched the video many times. I don't know the answer. That's why I asked you. You can help me. So here, I'm going to be very careful and seal up the incision. We'll take out the viscoelastic. On post-op day 1, you could see there was a normal looking bag in the pupil. Out there at the equator, I don't know what happened still. So even I've seen the patient post-op, I don't know. But there you can see there's maybe some wrinkling, I don't know. But luckily, patient did well, sees okay, sees fine. Very stable lens, not gonna go anywhere.
Maybe triamcinolone to be sure. Maybe triamcinolone to be sure. If you have
Triamcinolone will be
vitreous.
smart. Here you go.
Okay,
Here you go.
okay.
Triamcinolone is a good
There you go.
idea. And look at that. Thank goodness, nothing. Anyone from the audience know what happened? Seriously, I have no idea. Someone teach me. Someone must have seen this before. Come on, we have 1 million cataracts done in this room. Half of those by Neto. But no one's seen this before? So see, you never know what surprise you'll get in the operating room. But I think that was, for me, was an easy way. Let me just get out of here. Microphone.
How did you inject your CTRs? Manually or with the injector?
This is with the injector.
You use the injector.
Injector in the right hand, and then Sinski in the left hand to help dial it in.
And where to start? In the dialysis or near the dialysis, opposite
In this
the
case, I
dialysis?
started away. So the dialysis was, let's say, at 10 o'clock. I started the CTR going in, and maybe like at 2 o'clock. So away from that.
Good.
But I don't know, maybe it ripped the equator of the bag with the, I don't know. I just don't know. But regardless, we're done now. Okay, I think it's our last case. Pseudoexfoliation. Here's the case, pseudoexfoliation. Patient was sent to me already, another surgeon made an incision, and before doing the Rexus said, I'm out of here. The surgeon said, it's gonna be a tough case, and they send the patient to me. So what do you wanna do here? Game plan. The surgeon said when he went in the eye, he was surprised because he felt that there was already global zonulopathy. So he didn't want to do the case.
Yeah.
So do you want to just go do it, plow right ahead, don't trust the previous surgeon? Let's have everything ready, CTR, capsules, endovitrectomy, etc. Stop, look at the pre-op exam, plan for your money.
B.
Yeah, you have to be prepared for everything.
Yeah, so in this one, you notice that we got better dilation. So we put a lot of 10% phenylephrine, like 4 or 5 times. So really try to get more dilation. So I think it's going to help a lot. One of the danger signs in this patient is in the clinic, at the slit lamp, anterior chamber depth is like 2 millimeters. But on the operating room table, when the patient's supine, lying down, the AC suddenly becomes 3.5 millimeters. So there's movement of the whole lens iris diaphragm, and you get on the OR table, and whoa, the bag looks deeper. So now you know there's some global zonulopathy for everything here. So it's going to be a tougher case. Plus, I always trust the first surgeon. If I see a patient, this is a good pearl for a young doctor. If you see a patient, one eye had problems done somewhere else, and sulcus lens and iris damage, and the other eye is your turn for cataract surgery, you better believe you're going to have the same problems. Give the first surgeon the benefit of the doubt, because you're going to have the same challenges. So here we go. Pre-op exam, poor dilation sometimes means poor zonal support. Shallow AC, normal axial length, woo, loose lens iris diaphragm. And then phacokinesis can be sometimes very hard to detect. It's hard to sometimes see phacokinesis in the slit lamp. Or this one too, AC is deeper when the patient's supine. You start to do the Rexus and the capsule starts to wrinkle. These are all signs that you better be prepared to deal with. And this one I think is the most important. AC becomes very deep, whereas the pre-op was not. You can, for pseudoexfoliation, stretch the pupil. You can use a CTR. I think these are both helpful. I like to stretch the pupil, but you can certainly put a Malyugin ring in if you'd like instead. But these are certainly useful adjunctive things. Here you can see there's the pseudoexfoliation ring. That's not a Rexus, that's the pseudoexfoliation. And we put the viscoelastic in, and the AC looks pretty deep. So now going inside here, let's see. I just opened up his main incision. I didn't have to use a keratome because surgery was already attempted a week ago. And so it's not too bad. I'm measuring out the 5 millimeter Rexus. Definitely do not make a baby Rexus in pseudoexfoliation because they may get phimosis later. You don't want a small Rexus. So get a good Rexus done. And now here, how are you going to get the nucleus out? Because you know there's going to be some zonulopathy. Should you just do your standard technique, chop in the bag?
Chop in the back, yeah.
So here's some hydrodissection. Okay, you can do divide and conquer. Stop and chop works well. Phaco chop, horizontal, vertical, it's always the best. Or maybe flip it out of the bag.
Or horizontal chop, but maybe you can flip it if you want. But
Yes.
Neto, what do you think?
we use horizontal chop.
Yes, no, I would do it inside the bag with
the bag?
mechanical fracturing, yeah.
I like your technique. You have a mechanical fracture, just trapping the nucleus between the probe and the chopper. Yeah, I kind of like D though. I like to get it out of the bag. Is that crazy?
No.
But I think
Is this safe?
Yeah, as we said earlier, I think do what's best in your own hands. Yeah. So in your hands, if you're very good at stop and chop, stick with what's really good for your hands. And I think you'll do fine. I think the main issue in this case is not going to be nucleus removal. Nucleus removal should be okay. Just be careful when you're separating your pieces, when you're chop or stop and chop, you don't stretch out the bag too much. Don't put too much stress on the bag. I mean, it really need to float within the capsular bag and not put that posterior stress on the capsule. And then even if you're doing divide and conquer, that works fine too. And then, but for me, I just think if I get it out of the bag, I'm not going to put stress on the bag at all. I can chop it and whatever else. It's not a very dense cataract. I promise the cornea is going to be clear tomorrow. There's no damage to the endothelium, which you're worried about, I know. The patient's going to be fine. So I want to get it out of the bag. So we'll get it out of the bag. There we go. Boom. So there's the nucleus. Not too bad. And so more viscoelastic to protect the endothelium. And now we'll get the chopper in and the phaco probe. And then we'll go in here, buzz in, and let's chop it. Boom, 2 halves. And these come down very easy. Not a very dense cataract. You don't even have to do any more chopping. You can just emulsify these pieces pretty easily. I'm using the purple sleeve because the surgeon who did the original surgery made the original incision with a 2.8 keratome. So I want to fill the incision. So even then, it still has a little bit of a leaking here. So take this out nice and easy. Now, when the last piece of the nucleus comes out of the bag, I want to be super careful that the whole capsule doesn't come up. So I'll keep the chopper behind and the smooth part of the chopper to hold the bag back. And now it looks pretty good. Now it's going to be the challenge. How are you going to do cortex removal? Kind of normal. I'll be careful here. One thing I look at is I look at the rhexis edge. As I do the cortex, I want to make sure the rhexis does not move. If I'm trying to pull the cortex and I see the rhexis moving, then obviously I'm damaging the capsular bag or damaging the Zyner support. But here, it looks pretty good. And so we'll be able to get this here. Now, would you put a CTR on this case? It's not focal, it's global. No?
No.
No? Would anyone put a CTR in?
The back should look stable.
It looks pretty stable. There's no focal area, but the whole bag's a little bit loose. You know what? I'm going to put a CTR. But not like the last case. This time we'll do a better job. We'll put it right there in the bag. There you go. Nicely done. And now we'll put the lens in, and the rest of the case should be pretty okay. So here you can do whatever you want. So I'm just going to put a single piece in the bag. The only one you should obviously never do is never do B. B is terrible. Never put a single piece lens in the sulcus. That's always a mistake. But I think the answer for me here is going to be single piece. For the panel, same?
Yes.
Yeah, agree.
Do you make any changes to your IOL power because you think maybe the lens will sit more posterior in the eye? Because it's a little bit of loose zonulopathy, right?
Because of the CTR?
Well, the CTR is there too, but also just because, remember, the patient in general has a lot of movement of the lens iris diaphragm. So because maybe you think the lens will sit more posterior, maybe increase the power a little bit by half diopter, maybe? No.
It's a good idea. We don't use that, but it's a good idea.
I'm just to think, you know, like, because I just think the lens is going to be more posterior, a little deeper in the eye. Like for a post-vitrectomy eye, one of my secrets is, if it's a post-vitrectomy eye, whatever I think is the perfect lens power, I always add a half diopter. Because in those vitrectomy eyes with no vitreous, no anterior face, I always find the lens, effective lens position is a little bit more posterior. So I always want a little bit higher power. So I always add a half diopter to the IOL power. And of course, half diopter on the lens is only like 0.3 diopter in the spectacle plane. So it's not much. But in a case like this, yeah, I think I'll add a half diopter. Plus a little bit of myopia never hurts. I'd rather than the minus a quarter than plus a quarter. So let's take a look here. Here comes the lens going in nice and easy. Now that we have a CTR in. And then patient had a reasonable outcome. Here's the lens going in. There we go. Single piece acrylic. Get that unfolded. And then rhexis size looks pretty good. So 6 millimeter optic. So probably 5 to 5.5 millimeter rhexis. Remove the viscoelastic from behind it. And again, patients can have a good outcome. Sometimes with a lot of zonulopathy, you'll see little bits of lens material in the anterior hyaloid base. And of course, that I don't really worry about too much. And then I think this is our last case. Yeah, 2 minutes left. Any last comments or questions from the audience or the panel?
One tip that you may have significant zonulopathy is when you have eyes with same anterior, same length, same size, okay? And one of them has a much shallower anterior chamber. That may indicate that this eye has significant zonulopathy.
Yeah.
So you should be suspicious.
That's a great pearl. Very nice. Any other comments, questions from the audience? With 1 minute to go. All right, we do have some Cataract Coach t-shirts to give away right there. If you subscribe to the Cataract Coach daily email, show me. I'll give you a t-shirt. We'll get some t-shirts to give away. But otherwise, I want to thank you guys. Such an honor to be part of your meeting, part of your family. I really had a great time. I wish next time I could stay longer. We'll be back in 2027 for the 10th anniversary. And then I'll come to spend 2 weeks here.
Okay, Uday, thank you very much. Muchas gracias, Uday, por habernos acompañado en estos 2 días. Y creo que te tenés que ir porque tu avión te está esperando.
Okay, I'm ready. Yeah, I'm a boy.
El piloto te está esperando.
Okay.
Me está llamando.
Okay, good. Thank you, guys. I appreciate it. Thank you.